Thank you very much, ladies and gentlemen. Once again, on this Sunday, we are back with the webinar on US and ERCB from basics to advanced. I'm really thankful to Professor Anthony Teoh for sparing his time. I understand that it's quite late in the evening in Hong Kong, and he has been very kind to spare his time for the for Pakistan side of gastroenterology and Asian endoscopic ultrasound group. Uh, Professor Teo, exactly the same way as all his seniors in the Chinese university. Majority of them have been those surgeons, but they have a great interest in the endoscopy and in the advanced endoscopy. Uh, uh, in Hong Kong, the advanced endoscopy, in particular the ERCP, US, and conventional other aspects of the endoscopy are very well developed. And I have the honor to attend Chinese University way back in 1994, 95 for about 2 weeks or so, and enjoyed my stay very much over there. Professor Teo has been uh, leading name in research in the US and ERC. There have been a number of publications to his credit, and he has been very active on the frontiers of education in the US and ERCP. I requested him to deliver a talk on complications of ERCP, and I'm sure that he's going to guide our students on the fine aspects of the complications and how to avoid the complications of ERCP. First to you, all yours.
Thank you. Thank you for your kind introduction, Professor Kias. Good evening, everyone from Pakistan. It is my great honor to be delivering this lecture on complications of ERCP. I'm going to start to share my screen. So it's not too late now in Hong Kong. It's 9 p.m. I think it's around 6. So hopefully I won't go on for too long to disturb your dinner time. And let's start with the lecture. Can you see my PowerPoint?
Yes, we can see that.
Okay, so I'm going to be talking about prevention and management of adverse events during ERCP. So as we know, ERCP is actually quite a safe procedure. If you look at the previously published rates of complications of ERCP, of the highest, the overall rate is around 4%. The most concerning to many endoscopists is the risk of pancreatitis, because with pancreatitis, if patients have mild attack, then usually they stay in the hospital for a slightly longer period of time. But if they have a severe attack, they may be in hospital for weeks. And if they do have a cancer at the same time, that means there will be a delay in their treatment and subsequently possibly a much more difficult surgery. So this is one thing that a lot of endoscopists will try very hard to avoid, and but at times it is also out of our control because although we may do all the described methods of preventing pancreatitis, it can still occur. Other risks of complications like bleeding, around less than 1%. Infective complications like cholangitis, cholecystitis, again, very low percentage. Risk of perforation, either bowel perforation or sphincterotomy perforation, again, is very small. So overall, it is a safe procedure. Certainly it depends on what kind of interventions you're doing and also whether the patient has had a prior sphincterotomy or not. But this is the overall risk in general. There are several things that we need to be aware. First of all, we try to avoid doing ERCP as a diagnostic procedure. Back maybe 10, maybe 20 years ago, when we didn't have EOS MRCP, we still had to do ERCP as a diagnostic procedure, performing a cholangiogram, trying to see if there's any issues with the biliary tract. But I think nowadays we should try to avoid this as much as possible because we have many options like EOS and MRCP. And we can definitely, ERCP is more targeted towards the therapeutic procedures. Of course, we should choose the right patients. We don't do ERCP in every single patient. And even in patients with deranged liver function, we can try to stratify the risk of having a bile duct pathology and do ERCP in the right patients. Certainly the correct techniques is of paramount importance. If you happen to cannulate the PD, you have very high pressured injections in the PD, these are definitely high risk for causing pancreatitis. And last of all, of course, you need to recognize the complications if they happen and have apply appropriate management accordingly. As I mentioned, it's best to know more before ERCP. Now that we have many options in performing cholangiogram. If you have access to MRCP, definitely this is a very the preferred option of imaging the biliary tract. In some parts of Asia where health services are provided by government hospitals, sometimes MRCPs needs to be wait for a long time. So, for example, in Hong Kong, a government hospital, if you don't have money, you have to wait for almost a year for MRCP. So, in fact, in those hospitals where endoscopists are able to perform EUS, they would actually prefer to do a EUS plus a minus ERCP, especially in patients with an intermediate to high probability of a biliary tract pathology, because we can deal with the problem in the same admission and avoid the need to wait for a long time for the appointment for your MRCP. But definitely both procedures have been shown by multiple studies to be comparable. And certainly we should look at the patient on a patient-by-patient manner. There are several described criteria of the presence of for example, common bile duct stones. If the patient has a dilated bile duct ultrasound, clinical cholangitis, and high bilirubin, obviously these are very strong indications for ERCP. Whereas in patients with slightly abnormal LFTs, history of gallstone plus or minus pancreatitis, but the ultrasound shows a normal duct, then these are so-so patients. And in these patients, we tend to do a US first. And if US see some abnormality, we would do a ERCP in the same setting. So as I mentioned, the potential adverse events after ERCP include post-ERCP pancreatitis, perforations, sphincterotomy bleedings, and also trapped baskets. So I'll go through these adverse events one by one and see what everyone has think about all these developments recently. Post-ERCP pancreatitis. So previously, there has been multiple studies looking at risks of having a post-ERCP pancreatitis. I think in the States where they have a lot of diagnosis of SOD, sphincter of Oddi dysfunction, this is a risk factor. I think in Asia, we don't really diagnose this condition. We don't think that this exists really. So we don't really have these risk factors. I'm not sure the situation in Pakistan, whether you do diagnosis of SOD, whether you do sphincter of Oddi manometry, but this is not really an issue for us. But other factors, certainly, a female, normal duct size, young history, young patients, history of post-ERCP pancreatitis, pancreatic duct diffusum are all risk factors of PEP. And in the States, of course, if the patient is a lawyer, it is also a risk of developing complications. So if you look at all these risk factors, you can really tell ERCP is most dangerous to all those who actually need it least. During the procedure, there are also a number of risk factors, like if you need to do a pancreatic sphincterotomy, more than 8 cannulation attempts, pancreatic injections, particularly if you inject under high pressure, which you are seeing the side branches, which is called the accelerization. This is definitely a risk factor for PEP. Pancreatic duct instrumentation, ampulectomy, small balloon sphincteroplasty, meaning if you are dilating the sphincter to less than 10 millimeter in size, this is a risk factor for post-ERCP pancreatitis. Whereas if you perform a large balloon sphincteroplasty, more than 12 millimeters in a dilated duct, in general, this will not be a risk factor for developing PEP. So this is a patient that I've done a few weeks ago. It was a difficult ERCP, so I just want to share the video with you. So at this juncture, I already had a wire in the pancreatic duct. You can see it on the X-ray films. And why this was difficult? Because the duodenal mucosa was very redundant. Right now it's okay, but as I am manipulating my sphincter tone, I try to angulate more towards the 12 o'clock. You can see the direction is very different. And afterwards, the guy wire went into the bile duct quickly. So at this point, I didn't imagine it to be difficult for a sphincterotomy. So I actually pulled out the guide wire in the PD. And now you can see the duodenal mucosa being very redundant and also being having some peristalsis. So as I cut, the upper mucosa actually comes into the way of the cutting. So it becomes, the view is slightly obscured and a little bit difficult for complete sphincterotomy. So right now I have a good view. I quickly cut, and but then the mucosa starts to come into my way again, and I had to pull back. So this happened a few times, and then eventually I decided that I'm going to do a balloon sphincteroplasty because the patient had a stone. So I decided to pull out the sphincterotome and change the balloon dilatation. So you can see the CBD is not very dilated. It's around maybe 13 millimeters. So I dilated to around 10, and the stone was a small stone. And when dilating, I knew there was a small sphincteroplasty. So I had it a little bit longer than the 1 minute, and then changed to a balloon. You can see a small stone right there, and try to drag it out. So the whole procedure wasn't particularly long. I mean, it was around 20 to 30 minutes, but the patient complained of severe pain afterwards, the procedure. So CT next day, so there was a post-CRCP pancreatitis. There was some collection around here. So there were actually a few things that I could have been done during the procedure or immediately after procedure that may help prevent this to develop. So I'll go through the literature supporting these ideas, and hopefully we can try to avoid this complication. So in terms of reducing CRCP pancreatitis, they can be divided into other pharmacological methods or some technical methods to reduce PEP. In terms of pharmacological methods, I think most of us know about rectal indomethacin. So the landmark trial was published in New England Journal of Medicine in 2012. They used rectal indomethacin 100 milligrams immediately after ERCP. So this is immediately after ERCP. They recruited these patients. The major criteria are those that I've mentioned just now, or those who have minor criteria which have more than or equal to 2 of these criteria: age less than 50, female sex, recurring pancreatitis, and so on, as potential inclusion criteria. So in this study, they managed to show that with rectal indomethacin immediately after ERCP, they can reduce post-ERCP pancreatitis from 17% to 9.2%. And in terms of moderate to severe pancreatitis, from 8.8% to 4.4%. So, and all these differences were significantly different, whereas the risk of adverse events were not significantly different in terms of GI bleed as well as renal failure. And very often we also question whether a similar set of NSAIDs like diclofenac is actually helpful. So actually, this was a study published way before the New England Journal of Medicine study in gastroenterology. They actually used diclofenac, and they also managed to show that the use of diclofenac was similar to indomethacin in reducing the post-CRCP pancreatitis from around 7% to around 7% in the intervention group versus 70% in the control group. So both drugs seem to be equally effective. Thereafter, a Chinese group published a paper in Lancet comparing universal pre-ERCP versus selective post-ERCP in indomethacin to prevent pancreatitis. The idea is if we can give all patients pre-ERCP rectal indomethacin, does this actually help versus just being selective? Just giving rectal indomethacin in those patients with high risk of post-ERCP pancreatitis. So single dose, rectal indomethacin, 30 minutes before ERCP versus post-procedure indomethacin in selective high-risk patients, as I mentioned just now. And in this study, they actually found that in patients where we give universal pre-procedure indomethacin, 1,300 patients, they found that they can reduce the post-ERCP pancreatitis even more to less than 4%, to around 4% from 8%. And the post-ERCP pancreatitis in high-risk group, 12% to 6%. And this is almost significant. So meaning that instead of giving selective, perhaps we should give all patients undergoing ERCP pre-procedure indomethacin. And given that the drug is actually not very expensive, I think this is also a reasonable strategy. Another study also looked at other drugs other than rectal indomethacin. So this study looked at sublingual nitrates in addition to rectal indomethacin. So 5 milligrams sublingual isosorbic dinitrate versus rectal indomethacin alone. They found that with this combination therapy, they can reduce the post-PEP from 15% to 6.7%. And the absolute risk reduction was 56.2%, with absolute risk reduction of 8.6%, and the number needed to treat was 12. So again, favoring the use of sublingual nitrates. But the main issue is we need to exclude patients who have a cardiovascular disease if we are giving sublingual nitrates to these patients. Another study published more recently is the use of looking at the use of aggressive fluid titration. So of course, we have to exclude patients who have a risk of fluid overload, like heart failure, renal failure. And how do we give this aggressive fluid hydration? It's by 3 cc's per kilogram per hour. So if there's a 50 kilogram patients, we need to give 150 cc's per hour. Then followed by a bolus of 20 cc's per kilograms immediately after the procedure, and then continue at the same rate for another 8 hours. So actually a lot of fluids are given in this regime, almost 4 liters over a day. So really the patient needs to have no risk of fluid overload to receive this therapy. But if you look at the results, in the patients with standard hydration, it's not a very big study. 23 patients, 70% with PEP, but 0 in patients with aggressive hydration. And in terms of total fluids in the 24 hours, 2 liters versus almost 3.8 liters. So you are giving a lot of fluids to these patients. Another thing is the rate of hyperamylicemia as well as pancreatic pain is also much less in the aggressive hydration group, although this did not reach statistical significance. Apart from pharmacological methods, also ERCP, during ERCP, we can do a number of things to reduce post-ERCP pancreatitis. First of all, our technique. Just now we mentioned we should try to avoid PD cannulation, avoid injecting contrast in the PD. And also a very important point is to actually, during cannulation of CBD, try to use a guide wire directed cannulation. So some of us, when we first started learning ERCP, we were used to contrast guided cannulation. But with many studies performed recent in the past 10 years, definitely has shown that if you use guide wire guided cannulation, it can reduce post ERCP pancreatitis, but up to 3 times. So definitely this is the suggested method for cannulation. So this is a patient, again, a difficult cannulation. A PD wire has been inserted, and I was using a double guide wire technique. If you look at the papilla, you can sort of know why this was difficult to cannulate, because there's a very long intraduodenal portion of the papilla, so it's very floppy. And the way I see double guide wire cannulation, apart from pulling the papilla straight, it also sort of tells you approximately where the CBD is. So I always, after the PD wire insertion, I always take a look at the papilla. So the CBD should be, opening should be around here, slightly higher, and then angulated towards the 11 to 12 o'clock position. So if you look at my catheter, it comes in at this direction, slightly higher, and angulated to the 11 to 12 o'clock position. And with first pass attempt, already the guide wire was already passed into the CBD. So right here, the guide wire going to the CBD. Another patient, this is a more of an awkward position. I had to cannulate with the long scope position, and the papilla was slightly further away, again in a diverticulum. So you can see my scope position is very unstable. And right here, I'm not going in. So you can see my scope position. I was pushing in longer and longer until I have a fully long position. And now the papilla was in a slightly better position for cannulation. So right there, I sort of engaged something. And then I went into a duct. I wasn't sure, so I injected a bit of contrast. And this was a PD. And when cannulating PD in long position, it's a little bit difficult. So you need to angulate the sphincterosome in the right position, in the right direction. But then eventually I went into the PD. So I was doing a double wire technique with a long scope position. So I had to reduce the ERCP scope first. And with my catheter in the deep PD, I was able to reduce without losing my position. So I carried on with using a double guide wire technique, and then the insertion of PD stent, because already I had some contrast in the PD. And then afterwards, I used cannulation on top of the PD stent. So the PD stent actually helped in pulling the papilla straight. Right now, my knife was at a much better position, and I was able to cannulate the CBD. So the use of PD stent is also very helpful in helping cannulation, but at the same time, it also reduces the risk of pancreatitis. When we insert a PD stent, we need to be aware to avoid repeated PD cannulation. The PD stent also helps us to locate the anatomy. The pancreatitis is usually located at 1 to 3 o'clock. It pulls the papilla straight so that it allows us to identify the CBD. Sometimes when we use the double wire technique, the PD wire actually limits the movement of the endoscope. So once we insert the PD stent, our scope movement is freed, and cannulation is much easier. And of course, this insertion of PD stent helps to reduce pancreatitis. And this has been shown by multiple studies that the use of PD stent helps to ensure drainage of the pancreatic duct, reduces the risk of a swollen papilla, and hence the risk of PEP. So then the next question we often try to ask is whether both methods help in terms of providing prophylaxis to PEP. So whether you do a maximal pharmacological prophylaxis in terms of giving everything you know can help, like indomethacin, isosorbate dinitrite, IV fluid with rectatus, ringer's lactate, plus PD stenting, versus just a pharmacological prophylaxis alone. So in this Japanese studies, they actually found no difference in PEP. So if you already have maximal pharmacological methods, perhaps adding an additional PD stent may not be clinically effective, but sometimes for an endoscopist, it still feels better. So I have to admit, sometimes if I feel risky, I still put in a PD stent. So just to give you a summary, recommendations to prevent PEP: routine rectal indomethacin before, preferably, but if not, after ERCP as well. Sublingual dinitrate or 250 micrograms of somatostatin as alternative. Aggressive fluid hydration before and after ERCP. Placement of a 5 French prophylactic PD stent if other methods are not used. Of course, don't forget your techniques. Try to reduce the number of cannulation attempts as low as possible, reducing the number of PD guide wire insertions. If you need to do a precut sphincterotomy, try to do a needle-nose fistulotomy and avoid small balloon papillary dilatation if possible. So moving on from PEP, I also want to discuss a bit about other risks like perforations. In general, we can classify perforations into a few types. Type 1 is our luminal wall perforations by the scope. Type 2 is sphincterotomy-induced perforation. Type 3 is guide wire perforation of the PD or CBD. And type 4 are just trigenic retroperitoneal air, which we often don't know what happened, but most likely is due to a post-sphincterotomy perforation. So this is a CT of a patient complaining of severe pain after ERCP, and it shows the presence of retroperitoneal gas. Very often, if it's just gas, then these usually settle with conservative management with drip and suck and antibiotics. And often the pain goes away in a few days, and you can resume the patient on a regular diet or do a contrast study before you start so. This is another patient where there is a contrast extravasation during stone extraction, and then you can see the cholangiogram just looks scary. Another patient with a scope-induced duodenal perf at the time requiring surgery and also cholecystectomy. And this is another CT showing you some retroperitoneal gas. Nowadays, I think most of the perforations, even if it's scope-induced, we can deal with it by endoscopic methods, either by just easy clips, or if you have the access to a vessel, then it can also provide a very good way of closing a scope perforation. So this is a scope-induced perforation in D12. It was a very clean perforation, so we decided to close it immediately with Ovasco. So right here, you can almost see the perforation, which is just here, right there. It's very round, cleaned wall. So we decided to close it with a Ovasco. There's a size limit to how large of a defect we can use. We can close with the Ovasco. Usually around 1 centimeters or so. Here we're using a biclip. It has 2 arms, which allows a clipping of the 2 edges of the mucosa. And then slowly, we try to approximate the 2 edges. And the reason why we need to clip both sides is Ovesco, you only have one chance. So if you misfire, it will definitely be in your way. So we need to be 100% sure that we have clipped both sides of the mucosa. And if we fire it well, then it gives you a very secure closure. Another picture showing you a big post-sphincterotomy perforation. There are two ways where you can deal with this perforation. Some have described using a clip to close this. I think most people would be happy to insert either a plastic stent or a fully covered metal stent to actually exclude this perforation after sphincterotomy. Bleeding after endoscopic sphincterotomy is also sometimes very difficult to deal with. Most of the time, these bleeding are self-limiting, but occasionally these can be a very severe bleeding from spurters. So there are a number of risk factors of bleeding for bleeding after sphincterotomy in patients with coagulopathy, renal failure patients, or if they are on anticoagulants, cirrhosis and cholangitis. In general, aspirins or NSAID are not risk factors, and actually we don't really stop aspirins anymore. If the patient is on double antiplatelet, then we will try to stop one single antiplatelet agent and carry on with the aspirin. In some parts of the countries like India, where there's a high incidence of a portal biliopathy, we should be aware that one of the risks of bleeding, one of the causes of bleeding can be from hemophilia, portobiliopathy. So in terms of treatment, I think most of the time it's just, if it's just a minor bleeding, and if you still have the wire in the bile duct, I would perform a balloon tamponade to control bleeding. If it still doesn't work, I would inject with adrenaline. Recently, I've also been quite successful in using coag graspers. If you are practicing ESD or you are ESD practicing ESD in your unit, you would have access to small size coag graspers used in the large bowel. So these would be good options for hemostasis, particularly in post-sphincterotomy bleeding. Clips are okay to use. In the past, it's very difficult to apply because the bridge actually limits it from opening closer. But recently, with the new newly designed clips like the Microtech clips or the multiple opening and closing Coke or Olympus clips, these are much easier to close even if the bridge is inside you and if you are bridging up the device. Very rarely we will need to perform an angiographic embolization and finally a surgery, but again it's very uncommon. Another option, which I did not mention here, is the use of a CRE balloon. So particularly in patients where we have done a large balloon sphincteroplasty, if the balloon is still inside you, you can always inflate the balloon again and have hemostasis to control any difficult bleeding. Finally, this is a complication of where some of us may have experienced is the use of baskets as the happening of a basket stone entrapment. So in the past, this complication has to be dealt with surgically. You can see a trapped basket here, and we would perform a cholecystectomy as well as the ECPD in the same juncture. To deal with this situation, I think one of the important things is to avoid this complication. So when we see a large stone, there are several things we can do to prevent a stone infection. First of all, is we can do a combined sphincterotomy plus a large balloon dilatation. So usually we would do a limited sphincterotomy around half to a third of the papilla, followed by a large balloon sphincteroplasty up to the size of the bile duct. So usually this is between 12 to 50 millimeters. You can see right there, the balloon is inflating, a large balloon like that. And as opposed to a small balloon sphincteroplasty, these types of sphincteroplasty really don't have a lot higher risk of pancreatitis. And in our publication 7 years ago in gastroenterology, we have shown that for stones larger than 15 millimeters, the stone clearance rate is much higher. And if you use a combined technique, the need of mechanical lithotripsy is significantly smaller with the sphincteroplasty group. Also, the cost can be reduced if you use the uh, combined technique. Definitely, if you see large stones, don't hesitate to use a BML. This is because if you don't use them, you might regret it when you try to take it out from the papilla. The method to deal with a trap basket is you need to cut the wire and make sure you have a long wire left behind, because you would need to thread this through a Sohendra stone crusher. The guide wire goes here, and we need to fixate it over this handle and use the external crusher to go down the basket, and you eventually fracture the stone. Sometimes if you have this wire too short, then you cannot mount it into this Sohendra lithotripta, and that's when problem arises. So just last week, there's a case for trap basket. The wires were very short, and then the patient had to transfer from another facility to our hospital. And luckily nowadays we have the use of a spyglass that allows us to insert into the bile duct. So right here, we try to use the Sohendra dilator, the lithotripta. It didn't work, and then so we had to use the spyglass right there. So with the spyglass, we can fracture the stone, which is stuck at the basket. And after we fracture it to a certain size, a much smaller size, and then finally we're able to more and more fracturing right there. And then eventually we're able to take it out from the duct right there. So I think nowadays a trap basket mostly dealt with endoscopic methods. Of course, there are other described methods like using another BML to catch the trap stones. Of course, all these can be tried. So I think I'm going to conclude this lecture by saying that the ERCP is a safe and low-risk procedure. Adverse events are best managed by prevention and judicious care in performing the procedure. Thank you for your attention.
Thank you, Professor Teoh, for a very nice and elaborative lecture. That was wonderful and full of information. I'm sure the audience must have benefited a lot from this lecture. There are lots of questions which have been posted, a few directly to me, a few in the chat box, and I shall ask you one by one. Uh, what is your experience about SOD? Do you see frequently in China, in Hong Kong, and uh, you know that we don't have manometry. Any patient comes with recurrent pain and dilated duct in the absence of other suggested things, US normal. We straight go for endoscopic sphincterotomy and see how do things go. What's your experience in Hong Kong?
We in Hong Kong, we actually make very few patients to diagnose them with SOD. Even with Peter Cotton's recent trial published in the England Journal of Medicine. Basically, he's with that study, they have shown that if even if you perform a synchterotomy in the so-called SOD1-2 patients, actually their symptoms do not improve. So I think he has pretty much disproved the concept of SOD. And in Hong Kong, in China, actually, we very rarely make this diagnosis. How about your experience in Pakistan?
I think in Pakistan, it's a overlap kind of functional disease. You are never sure whether the symptoms are coming from the parabiliary tree or they're coming from the mind of the person or they're coming from the other parts of the gut. So it's always an overlap kind of thing.
Yeah,
Uh, it's all difficult to say, but if the duct is dilated, or if you find that the MLAs are going up, or if you find that CVD size is up, in that case, in the absence of any pathology with EUS or with MRCP, our policy is to go for endoscopic sphincterotomy and see how do things go afterwards. But then there has to be something physically or biochemically positive. Only then an intervention is warranted. Otherwise, no intervention is warranted in these cases.
yeah. I think if you have deranged liver function, I think a lot of time these patients actually have papillary stenosis. So then we would perform a papillotomy for these patients.
That's right.
Dr. Saab, how are you?
Hi, Saad. Hmm.
Nice to see you. You're muted.
You need to unmute yourself. Saad,
We can
need to
see you.
unmute yourself.
Yeah. So yeah, I mean, this sphincter of Oddi thing is a difficult one, really. I mean, I think yes, you've got abnormal LFTs or a duct dilatation, then, and the symptoms are classical. It's worthwhile. Otherwise, it's always a difficult one, and this is the one where a lot of patients would come back and say, "You've already done a procedure, and we have not been helped," and so you are more likely to get into trouble. But I agree. I mean, I think 1 and 2 are fine. But it becomes difficult when you have a classical symptom, and but you really can't put your difficult one. And this is
Yeah,
where you get into trouble with complications. I mean, as pancreatitis, um, as you know, it's a bigger problem here as well.
yeah,
Now,
definitely.
there's a question from the audience. What exactly constitutes pancreatitis? But does that mean that a person has got raised amylase and pain in the tummy post TLCP for a couple of hours, or there's something specific in terms of duration and in terms of amylase level before one can label from the medical legal point of view and from the clinical point of view a significant pancreatitis? What
I think for
constitutes?
diagnosis of pancreatitis, it still follows the same diagnosis. So you need to have pain and clinical pain as well as raised amylase. If there's just raised amylase without pain, I think most of us would not consider that as a clinical pancreatitis.
How long the pain should be there? Should it stay for longer than 24 hours, longer than 6 hours for medical, legal, or clinical labeling point of view? Or any pain which lasting for any time
It's
period with amylase, that's good enough to
it
label a person suffering from pancreatitis, post ESCP pancreatitis. Anything? Are you with me?
Yeah, well, actually, I think in terms of time, we do not have a set time, but I think studies may say around 6 hours as the time required to be present. But I don't think, I'm not sure if the pain actually correlates with the risk of the severity. I think in terms of the pancreatitis, probably the severity is more important. And so if you have moderate or severe pancreatitis with complications, that's probably more relevant in terms of the legal point of view.
Any this
I,
comment from
I I feel. Don't you think if your patient has got pain bad enough for them to be admitted with a high MLAs is where you will have pancreatitis, and then whether it's mild, severe, or moderately severe, that depends on how the next few days go. If the patient settles down
Yeah.
within the next 48 hours, I think this would be labeled as mild or insignificant pancreatitis, really. But anything more than that, I assume. But admission, I think, should be the thing. I mean, otherwise you will have little bit of pain that happens after ERCP, and amylase is very much high in a significant percentage of patients anyway. So amylase becomes
Yeah.
difficult. But I think without admission, but if you need to admit,
The pain is persisted for longer than 6 hours and requiring painkiller injection, and amylase levels are three times the basal level, there should be the clinical evidence that the person has got pancreatitis and the person should be managed on the lines of acute pancreatitis. Whether it may turn out to be a significant pancreatitis or it turns out to be a clinically insignificant pancreatitis, it's the time it's going to tell. Otherwise, clinically, for every patient who presents with pain lasting longer than 6 hours, requiring painkiller injection, and three times the upper normal limit of amylase, they need to be kept under observation and managed on the lines of acute pancreatitis.
there's another question we asked which says about prevention or prophylaxis of pancreatitis. What size of stents do you prefer,
Yeah.
Anthony?
I
Three
usually
French
use
or
a
five
5 French 5 centimeter.
What
You
size?
go for 5 French, 5 centimeter, or 3 French? Would you prefer
Like
3 French or
pigtail,
5 French?
single pigtail or straight pancreatic, and what size? Do you cover
I
the?
usually use a 5 French 5 centimeter single pigtail, and I would usually cut the flap off to allow easier migration of the PD stent from the PD.
Okay, right.
That's
So you
that's that's
cover,
that's what we do as well. I mean, 5 French, 5 centimeter, and single
Yeah.
pigtail.
and
I
you use this.
avoid putting
Yeah.
prophylaxis. I think we have to be strong on this one. Prophylaxis, we should avoid using straight stents or CL, because I've seen migration causing havoc for someone that you are trying to prevent pancreatitis, ending up having chronic pancreatitis because of stent damage and injury. I think straight stents must, if possible, avoided at all costs. I don't know what you feel.
Andy, can you clear up a fine
Well,
point?
definitely. Yeah,
Should it be
definitely. We are using mostly single pigtail, so
Single pigtail, yeah.
we should.
so? Andy, you're using 5 centimeter stent. Do you try crossing the genu, or that is not necessary? Because there's been a recent paper on that crossing the genu reduces the chances of stent-related pancreatic duct damage. Is that realistic apprehension or is it unrealistic apprehension?
So if you are crossing the genuine, meaning you're gonna use a longer stand, is it?
Yeah, that's
Yeah.
right. Long.
Longer than 5 centimeters. Well, I think for most of our patients, we only need the PD stand for a few days, right? So, if you have it for too long, I'm not sure how well it's gonna migrate, how well it's gonna be able to pass out by himself. In the same way, some people use 3 centimeter stents. I think that's a bit too short. Often it gets migrated too early. So that's from our experience, we learned that the 5 centimeter stent actually works better.
Hmm. And in your own practice, Anthony, how long do you leave the stent there? When do you recheck the
So
stent
we
position?
usually take an X-ray at around 4 weeks later. I think 80 to 90% of the time these stents are passed out spontaneously. If they don't, then we will arrange another endoscopy to remove it.
There's another query from the participants that you have said that bigger sphincteroplasty size bigger than 50 millimeter are associated with lesser chances of pancreatitis. Uh, and the smaller sphincteroplasties are associated with the higher chance of pancreatitis. So, if the duct size is small, say 10 millimeter or 12 millimeter, do you match it with the size of the CVD, or you just go with the bigger size amploplasty?
Yeah,
Tailor this.
so in some patients where, for example, if they have coagulopathy, you really don't want to do a sphincterotomy, then you might choose to perform a small size sphincteroplasty. In those patients, then I would dilate up to the size of the bile duct or the stone. But then you would try to keep the inflation for a bit longer. So there are studies showing you that 1 minute versus 5 minute dilation, and actually, if you keep the balloon on for longer period of time, the risk of pancreatitis can also be lowered. So that's one thing you can try to practice.
So
I,
low,
Anthony, Do you always do sphincterotomies when you're doing because your intention is to remove the stone initially and then you do a sphincteroplasty? So I don't know. In our experience, we feel that once you've done a good but adequate sphincterotomy, and you do a sphincteroplasty, the risk of pancreatitis is almost other than the procedure itself, really the sphincteroplasty doesn't actually increase the risk of pancreatitis.
Yeah, I think for a patient with very dilated ducts, I think with the sphincteroplasty, you can actually open up the papilla a bit more. So for very large stones, there might be some benefit. And I think just now Professor Gier was talking about small stones. So particularly in patients who are on anticoagulants where you don't want to perform a sphincterotomy. So this is one option you can do. It's not a very common indication, but if it does happen, then that's one of the options you can consider.
Andy, there's a question from the audience that in case of UC, we tend not to use NSAIDs. So, in a patient who's suffering from ulcerative colitis and CVD stone, will you like using NSAID, indomethacin suppository or diclofenac suppository in patients who are suffering from ulcerative proctitis and undergoing
Yeah.
ERCP?
So if they really have contraindications to NSAID, so as I mentioned in my lecture, there are other options, so which you can consider: fluids, resuscitation, nitrates. So these are other options you can perform. I mean, give to the patient.
Mm-hmm. Right. Every time you put in a wire in the pancreatic, do you put in a stent always, or it is after a certain number of guide wires going into the pancreatic duct, only then you're going to go for pancreatic stenting?
Yeah. So in patients where we put a PD stent, definitely there has been studies showing that the amylase can go up, but even with a wire in the PD, with the increasing cannulation attempts, there can be a high risk of pancreatitis. So I think it depends on how many times I cannulate into PD. So if there are more than 3 times, then I would generally insert a PD stent.
Hmm. Um, how frequently do you still use needle knife with the guide wire technique, with the number of years that you have done the ARCP? Are you still using at times needle knife sphincterotomy, or it's always that with the number of years that you have under your belt, needle knife is almost extinct? Because just few days back we had a hot discussion in our forum that what's the best utility of needle knife? Should it be in use by juniors, or it should be strictly only under the use of people who are very very experienced? What's your take on this?
Well, I think really the use of needle knife depends on your experience. So I think for us, where we've done enough ERCP, sometimes we take a look at the papilla, we already know this is going to be a difficult one. So for me, I would try, if I anticipate it to be a difficult papilla, I would try cannulation for a period of time, but not for too long, 5-10 minutes. If I think it's really too difficult, then I would actually adopt early precut sphincterotomy. So it's not something that is obsolete. Whereas if my junior has been performing a procedure for a bit of time, calling me for help, definitely I would try to do a cannulate first for another 5 minutes or so. If it's difficult, then depending on the experience of junior, if he is ready to try precut sphincterotomy, then I would let them perform the procedure under my supervision and take over if it is out of control. But I think it's also a learning opportunity for them to try to grasp hold of the technique of precut. So I think it depends on the experience of the junior. As to myself, it's not obsolete. I do precut sphincterotomy, particularly where I anticipate difficult cannulation. So I would do it earlier.
And a very interesting question from the audience. How do you define a large stone? What constitutes a large stone?
I think a large stone in the literature is defined by anything more than 12 millimeters. So, and in terms of large stone, in general, you would need additional devices like the use of BML or even spyglass or laser or additional techniques like combined sphincterotomy plus large balloon sphincteroplasty. So,
And don't you think there's more of a historical definition, because over the years, I know that stones up to 18 millimeter, we are able to take them out without any difficulty with the large balloon amploplasty. Um, and it's only the bigger stones that we really need to uh, think in different terms. I should like to take views of Saad as well, but first, Anthony, please.
yeah, it's more of a historical definition for sure. And with all these new techniques, definitely we are extending our boundaries in terms of the need for using additional techniques. But of course, we can have a new definition in 1 or 2 years time.
Unless we come up with a new consensus on the definition, all those stones with lots of facets and the size bigger than 15 or 18 millimeter, maybe they're the ones who are difficult to take out. But otherwise, most of the stones, even with a bigger size, especially oblong type, uh, as long as their transverse diameter is good enough to be taken out through the cut papilla, I think uh, we need to stay with the conventional measures. Another very interesting question. In case of impacted the basket, are you able to pass the spy scope easily through the duodenoscope? Is it easy or is it difficult? What is your experience?
So I think with a trap basket, first of all, you need to remove the basket from the duodenoscope and then have it separate from the duodenoscope. And then afterwards, only afterwards, the basket is removed, you can insert the spyglass
Okay,
into
it's
the
not
channel.
parallel to the strings of the basket. So you have to take out the endoscope. You have to remove the basket, and then put in the spy scope. And how easy it is to break the stones while the stones are impacted in the basket through the spy scope.
I think first of all, you need to gain some space. So very often when you are impacted the basket, you're actually pulling the stone early towards the lower CBD. So you actually need to push the whole system back up into the mid or higher CBD to gain some space, also that you can insert a spy and see it under direct vision. Of the ease of fracturing of the stone, of course, depends on the energy source. If you're using an EHL, it tends to cause a better fragmentation. If you are using a laser, it tends to be very focused on the fracturing. But either method usually takes time, so better to perform it under MAC or general anesthesia.
I think there's another question from the audience that in case of stone with stricture, how aggressive will you be in dilating the stricture?
Yeah.
Will you be taking the stricture dilated up to the size of the proximal duct, or you're going to go gradual, step by step? How do you manage stone with stricture?
Well, of course, yeah. So if there's a stricture, definitely for one, we need to rule out malignancy. Um, Make sure that you do a US or MRCP. There's no associated malignant pancreatic head mass. Biopsy if necessary. And if you're really dealing with a stricture, either from a stone-induced stricture or chronic pancreatitis, so I think you really have to deal with the stricture first. Otherwise, it'd be very difficult to remove the stone. So I think in terms of these strictures, most of us would use either multiple plastic stent techniques or a fully covered metal stent for a period of time. Make sure that the strictures is completely dealt with before dealing with the stone. That's what my strategy would be.
Hmm. Good. Saad, do you want to say something? Wait until the last minute.
Excellent, Anthony. Difficult things. I think large stones, one thing I would like to add, and that also depends on one's experience. So something that may appear large to me, Anthony might think it isn't that large, obviously. and also the shape of stone makes it very difficult, along with the duct size. So there are multiple factors that get into this stone thing. It's nice to see a round stone, even if it's large, and if it's a duct that's nicely dilated. Um, Other than that, I think the audience's remarks actually, Anthony, obviously may have or not have looked at it, but everybody is really enjoyed the talk, and I think the comments have been are actually very, very, very positive, Anthony, and you should know that people really enjoyed and learned from your talk today, and we hopefully will hear from you again soon with, I'm sure, something to do with the US.
Yeah, certainly.
Uh,
Let me tell you that Anthony has promised to come to Pakistan as well in February. Let's hope that the things stay good for Pakistan in terms of COVID, and hopefully we are going to host Anthony here in Pakistan on US workshop. He has promised me that he'll come to Pakistan, and let's see. And the one last question, which is interesting. How come in the Chinese University, Hong Kong, everybody is a surgeon and endoscopist, and there are not many medical gastroenterologists who are doing endoscopy or who have not come to the front line in the endoscopy?
Well, actually, we always pride our unit as a conjoined unit. So we actually have both gastroenterologists as well as surgeons doing all the procedures. I think you heard of Joseph Song, Francis Chan, even with my colleague Raymond Tang. They are all very prominent gastroenterologists and publishing a lot. So we try to have a cross training system where surgeons would train gastroenterologists as well as vice versa. So it's actually very much a conjoined unit. We would have a conjoined research meetings. So it's good to get everyone together because sometimes our thinking is a little bit different, and it's good to exchange ideas. So it's not only just surgeons.
Towards the end, that's a wonderful answer for me. Towards the end, it remains for me to thank Professor Anthony Teoh for sparing his time. I'm really thankful to you for taking out your time from the family day. It's a Sunday. I know it's very late in Hong Kong. And at the same time, it remains for me to thank my co-directors, Dr. Saad Niaz, sponsored Wilson Pharmaceutical, Dr. Nate Mushtaq. At the same time, all the participants who have spared the time on Sunday, which I know it's a very, very difficult that they take time out, but for the quest of knowledge, they have taken time. Thank you very much, and see you next Sunday.